Thanks for the opportunity to be here today. I feel like I actually benefit from going at the end of the line because I get to hear everyone else's comments and they keep igniting things for me as I think about what I was to speak about today. And I'm probably going to adjust some of my presentation as well based on that. But just in reflecting on my experiences and my interactions with community health workers in my various roles, I really saw a number of themes coming up in terms of not just the technical skills that we require from them, but those communication skills, the intuitiveness of doing the work, and working with caregivers. They're not just supporting the client, but they're supporting the family caregiver and encouraging them to take 5 minutes, building their confidence around entrusting someone else to provide that care and to take some of that time for respite. Thinking about my work as a practice consultant in the community, listening to Alicia's comments about these independent workers or live-in caregivers, and thinking about our role around supporting clients to access a program like CECL, which is a fabulous program, but walking through that lens of decision-making too around what makes a good employer and all of the tasks of being an employer. It's a daunting undertaking, the paperwork and the tax forms and all of that. So again, the impacts that has on the workers that are doing that work. Also engaging community health workers in more and more complex tasks. And Diana and I have had opportunity over the years to, be creative around trying to meet the needs of more complex clients, but also really pushing, I think, the limits of community health workers in terms of our expectations for what they're documenting, what their observations are, the whole reporting structure back to the case managers or whoever the people are in the community that are also supporting the clients. So I think that level of complexity is just continuing to increase. And then the hat that I'm wearing now, working in the REACT Adult Protection Program and working in the Patient Care Quality Office of Vancouver Coastal Health, where we are processing concerns coming to us from clients or patients that have been accessing our services. But, that often has an interface, too, with the workers that are meeting their needs. And, Anita, you talked about the complaint resolution processes and having good process, too, when a concern comes forward about a worker. So I've been just thinking about all of those things as I prepare to talk today. So I think I've prepared a very high-level overview of kind of the adult guardianship piece, and I think I'm going to skim through that quite quickly. I think it's really just to build the context for talking about what are the implications for community health workers. But we have a number of acts in BC that kind of come together to form the legislation around adult guardianship. And, I think more and more workers are having to be aware of what are all of these things people are talking about. I'm getting calls via the home support supervisor from the case manager wanting me to know more information and wanting us to be able to provide more collateral. They too in their work are having to live up to some of the principles in the Adult Guardianship Act, such as self-determination and choice, most effective but least intrusive supports. In the Act, we see court as a last resort, and we also see adults presumed capable. And although this is specific to the Act, I think that some of those challenges we see interfacing too around who's the person who's guiding the care. Is it the adult? Is it their adult children? Who's that person that's kind of driving what this care looks like? I've just provided a brief description of what the Adult Guardianship Act does to define a vulnerable adult. And in Part 3, it says that the adult is abused, neglected, or self-neglected and unable to seek support and assistance due to physical restraint, a physical handicap that limits their ability to seek help, and an illness, disease, injury, or other condition that affects their ability to make decisions about the abuse and neglect. In British Columbia, we have designated agencies are defined in the Act for following up and responding to reports of abuse or neglect. So that would be the 5 health authorities around the province, as well as Providence Healthcare and Community Living BC. So those are the agencies that have the responsibility. If there's concern about a vulnerable adult who's experiencing abuse or neglect, they're the groups to follow up on those concerns and conduct an investigation. the designated staff in those agencies must look into the situation. That is their obligation. They need to involve the adult as much as possible. Any criminal offenses must be reported to the police, and they need to keep the identity of the person who made the report confidential. And I'm going to come back to that later when we talk about the implications for home care, because I think this is a big piece for us to consider. There it is. This is the kind of branding that we've done in the REACT program, and at VCH, every employee has a responsibility to act, and we've put those eyes there to be the thing that builds some recognition around the work that we're doing and who needs to be aware of it, and trying to reach staff to help them understand their obligations. We've put the eyes there because they're common to any adult. They're gender neutral, there's no age, there's no ethnicity, they're just the eyes, reminding us to be aware and mindful. The branding also helps us to target our materials when we're communicating with staff about REACT kinds of issues, events, training, and awareness. Within the REACT Adult Protection Program, we receive reports from the community, from staff, from community health workers, from hydrometer technician checkers. I mean, the arena of people who can identify concerns about a vulnerable adult is huge, and our responsibility is to receive those reports and funnel them out, as well as central intake services, case managers, hospital social workers. There's a whole array of people in the system who are responsible for doing that piece. In the program, we provide some coordination functions and support teams around developing their workflows for reviewing these kinds of concerns. And we provide training to staff around recognizing, reporting, and responding to issues of abuse and neglect of vulnerable adults. In September of 2011, we launched a new curriculum for all of our designated responders in the system that are responsible for doing these types of investigations. And it's intensive, 11 modules, 3.5 hours each, that walk through all of the things from recognizing abuse, documenting cases, issues around consent and capability, ethical issues. There's a whole host of things that our frontline VCH employees need to be aware of. And that translates back to the community health workers, so many of the elements of all of these pieces that they also need to be aware of. The people in the system who are responsible for following up vary across the region based on if you're in an urban site or a more rural site, how individual teams have structured themselves. But generally, it's registered social workers working in a hospital environment, professional practice leaders, or practice consultants, whether they be in mental health or adult services, such as the family and social support practitioners who work in the Vancouver community area. Facility liaisons, so those are those people that kind of hybrid between the health authority and the residential care facilities. And then, of course, long-term care case managers. I've provided a really brief overview of the process for the designated responders to follow up on. It walks through documenting each step, interviewing the adult, assessing urgency. But the reason I put it in here really is to emphasize that each of these steps involve the community health workers. We're calling the home support supervisor saying, we're engaging in a process, we need your help. We need the worker to report this information. We need, we're kind of ramping up our expectation every time we engage in a more intensive process as well. And creating more pressure too, I think, for those workers to be kind of heightened in terms of, I need to be able to recognize things, there's concerns here. I think it can be quite a challenging time, and it puts pressures on organizations too in terms of supporting their staff around those kinds of demands and issues that are coming forward. A couple of other pieces around the process, sort of coordinating the assessment around the adult's ability to seek and refuse support. We're trying to understand, some of those functional pieces of how an adult is doing in their home environment, and much of that comes from the people who are there every day doing the care, asking them to provide that kind of information and assessment back to us. And coordinating the development of a care plan to provide support and assistance. So often does involve those home-based community supports, and how are we building that system of support around a vulnerable adult, and it's often engaging community health workers to do that piece. So it's really a crucial part of this work. Engaging the physician, reports to the BGT, reporting crimes to the police. You know, it's very stressful to think about, is this something I have to call the police about? You know, is this a reportable offense? And very difficult for workers when they're often the people who are reporting to us something that they've seen. You know, what's been the impact of that? You know, they might see things a few times and then start to reflect on it and be unsure about, who do I talk to about this? You know, was that a weapon that I think I saw? And how do I know? And I'm, you know, if the person that they're supporting they don't have the kind of relationship that, you know, they're chatting a lot during that care, maybe they don't feel comfortable pursuing things or saying something, what are going to be the reactions that they're going to get? Keeping the identity of the person who made the report confidential, and that's another one I'll kind of flag for when we talk about the implications, because I think that's also really key, and key messaging back to community health workers in terms of them raising forward an issue or a suspicion about something that might be happening to a vulnerable adult. I've just highlighted a couple of the avenues that a report could come forward. So for, you know, I'm thinking of the live-in caregiver who's not connected to a home support agency like Greater Vancouver or Beacon, or someone who's just hired privately. You know, what are their avenues if they're seeing something? And I think that there's two challenges about that. I think one of the challenges is how does that person know what the options are? How do they know how to access information about this? You know, do they have access to the internet? Are they able to Google and figure out, you know, what is abuse and neglect of adults? I mean, there's a whole lot of decision-making and steps and awareness that has to go with that. So certainly talking about, you know, who the designated responding agencies are, that they can make a phone call and talk to somebody and problem solve through their concerns, and that their identity will be protected, and talk about how that can happen to try and alleviate any stresses that they might be experiencing too while thinking about it. Okay, I'm almost there. For the contracted home support agencies, it's that dialogue between the worker and the home support supervisor, and then that supervisor back up to the case manager. And often, you know, I'd find then there would be, you know, is it possible to have that conversation directly with that worker, and they're going to be able to provide me with the first-hand information, but that's a time factor. It's, you know, additional stressors in terms of, you know, what kind of questions are they going to ask me? What level of detail do I need to be able to provide? Is there a wrong or right answer? You know, increased stress and pressure for people. And then for employees of the health authority. So in Vancouver Coastal Health, we have some workers that are through a contracted agency and others that are actually home support programs that are operated and staffed by VCH employees. So that's yet another avenue in terms of how do they report and making sure that they know who they can call to ask questions if they need to talk to a designated responder about something that they've seen that they're concerned about. We've also recently launched an online documentation system where people can submit reports online, and it enables us to track cases across systems and sectors. So if a vulnerable adult is in one community health area and ends up in a hospital and then ends up in Bella Coola, we're able to communicate sort of who's handling that investigation and that work. And so any employee would be able to submit a report through that system. And then just to conclude, my final slide talks about the implications for home care providers, and that's really the crux of the discussion today. You know, what is their knowledge of the risk factors or indicators of abuse, neglect, and self-neglect? What support have they been given to know what to recognize? You know, when we're training professional staff about that, we're having conversations about your own experiences and your own life, the lenses through which you're conducting your assessments and receiving that information and processing it and triggers. So what kind of support are we able to provide to these really frontline workers that are potentially in the midst of a situation? Ensuring that they have timely access to information, support, consultation, supervision, so they know that it's okay to talk about some of these things. I mean, we're still seeing that undercurrent of it's a family's business, and, you know, how much of that do I talk about publicly, and is this this is the dynamic of this family, who am I to judge? I think those kinds of questions need to be explored with consultation and problem solving. The concerns about the implications for reporting. Is it going to diminish my relationship with this person who I've been caring for? Is that adult child who I have some concerns about going to find out it was me? Are there going to be implications for my safety? Do I need to be concerned that I'm going to lose my job if I misinterpreted a situation and they found that there wasn't an issue? There's huge implications. Compassion fatigue and vicarious trauma. I think that those are both huge issues across the spectrum of home care providers, but also when we're dealing with issues of abuse, neglect, or self-neglect, more challenging experiences and more significant impacts on those workers as well. And I think earlier someone talked about the continuity of care piece, and I think that that's really key too in terms of the value that workers bring to us. If we're going through a process of trying to understand whether a vulnerable adult is able to seek support and assistance, that key criteria in the legislation, having that wisdom of the community health worker who's been with them, who's understood their functionality, who might have seen changes over time, is invaluable to us in terms of our work. So that's my quick blurb. And then the last slide is just given a couple of resources about the REACT program and then the value of community response networks and some great information available on the Public Trustee website as well. Thanks.